Thank you, Ria. Thank you, Nirupma ji. Almost everything has been covered by previous speakers. So almost I'm going to talk about only on calorie estimation, protein and fat estimation in decompensated cirrhosis with obesity, diabetes and sarcopenia. So prevalence is already covered by Ajay sir. Cirrhosis, malnutrition. It has been already covered, but just I will point out the reasons. Cirrhosis is a hypercatabolic state. When the patient fall into this decompensated cirrhosis, that is already a hypercatabolic state. In one study, resting energy expenditure was 20% greater than the predicted in 24 of well-compensated cirrhosis. So 20% greater energy expenditure needs additional 20% calories and 20% protein for compensated, which is already a 20% less. So maybe mediated by cytokinins activation. Then cirrhosis is a state of accelerated starvation, maybe due to raised alpha cytokinins, alpha TNF alpha 1 and 6. So these points should be considered to estimate energy and protein estimation. Leads to malabsorption of important nutrients like A, D, E, K, and 12. Folate and vitamin B12 and folate and thiamine deficiency leads to a lack of adequate food intake. So already covered which guidelines to use for estimation of calorie, protein, and fat for the decompensated cirrhosis. So earlier I have been using the EASL guidelines for estimating the calorie, protein, and fat. The EASL is European Association of Study of Liver Diseases. So they have released the guidelines, practice guidelines on nutrition in chronic liver disease. But the EASL only indicates kilocalorie per kg per day. But they have not mentioned the dry weight, estimating the dry weight for the compensated cirrhosis. So again, pens up parenteral and enteral nutrition guide by UK Dietetic Association, a pocket guidebook in clinical nutrition. By pens, here you can see they have this a proper equation for estimating the calorie, protein, and fat. So by pens, kilocalorie per kg per day and physical activities added. Then maybe compensated patient may not be having more of the physical activity, but they do have stress, which is already estimated here. Again, this is the calorie estimation equations by different guidelines. Like you can see, the red is by SPEN, blue guidelines by EASL, and green by PEN. So I am going to talk about the cirrhosis, decompensated, critically unwell hospitalized patients. So a decompensated cirrhosis patient need more of the calorie to compensate the greater to compensate with the to fight with the greater requirement of the 20% greater requirement of the calorie. So we must focus on the PENJ guidelines. PENJ estimates more calories than any other guidelines. You can see the SPEN has suggested only 30 to 35 kilocalorie per kg per day. And again, EASL only 35 kilocalorie per kg per day non-obese patient. And again, but these are the for compensated cirrhosis. I am going to talk only only on the compensated part. So 30 to 40 kilocalorie per kg per day is required for compensated cirrhosis. Again, compensated cirrhosis with obese and to lose weight. Sometimes we do see that compensated cirrhosis patients are obese and fall at least 20 BMI is 20, greater than 20. So accordingly, we need to design and restrict. We should calculate the resting energy metabolism at here, and accordingly we need to reduce the 400 to 800 kilocalorie per day. No other numerical equation for estimating requirement for cirrhosis patient with obesity, cirrhosis calculation from the EASL and SPEN. So here I would focus on this part only, suggested by Penge, and we will focus on the obesity to lose weight, to reduce this much of calorie from this resting energy calculation. And again, we have to add on PAL. Again, this is the equations for estimating the protein in compensated cirrhosis. Again, I will focus, see, here is the red is span, blue is easel, green in Penge. So again, the cirrhosis patient, not malnourished. So we can just give 1 to 1 kilogram protein per kg of dry weight. But again, span and easel is not talking about the dry weight. So we will focus on Penge. Again, Penge had described the this weight, dry weight. See, cirrhosis patient need 1 to 1.5 kilogram protein per kg of dry weight. Again, cirrhosis with compensated cirrhosis always with aim to achieve weight loss greater than, once we are talking about the weight loss, so we need to restrict the fat as well as the carbohydrate. Then again, we have to focus on the more of the protein up to 1 to 1.5 grams, so that the patient may not lose the muscle mass. The muscle mass depletion should not happen in cirrhosis patient. So up to 1 to 1.5 gram per kg per kilo weight per day of dry weight. Branch chain amino acid. Once we are talking about the protein part, we should focus on amino acid, aromatic amino acid and branch chain amino acid for the decompensated patient. Branch chain amino acid should be supplied up to 0 to 0.25 gram per kg per day with reduced risk of encephalopathy. Long-term supplementation have been found to be associated with the better nutritional acceleration and improved liver function and positive mental health. So the protein whichever we are providing should not be less than 1.5. Out of that, per kg, we should estimate or calculate 0 to 0.22 gram per kg per gram per kg dry weight. BCCA should be, the sources of BCCA are mentioned here: egg, whey protein. The higher amount of this BCCA per serving is, once we are allowing our patient 2 to 3 egg white that contains 5 to 5.5 gram branch chain amino acid in 2 egg whites. Whey protein, 2 scoop of whey protein provides 5.6 gram of branch chain amino acid. Pulses, curd, yogurt, chicken. Again, 2 pieces of each 30 gram. Low fat chicken preparation provides 6.8 gram branch chain amino acid. So we should focus on branch chain amino acid part for maintaining the muscle mass, especially patient with decompensated cirrhosis, frailty, and sarcopenia. And we should reduce the sources of this aromatic amino acid, which can lead to accelerate the HE condition. This high aromatic amino acid presence in proposed cause of HE acting as precursor false neurotransmitter as ectopamine. So we should try to reduce the presence of aromatic amino acid in our diet. Estimation of carbohydrate requirement for adults. So for primary goal of providing energy to is to provision of substrate for oxidation. Glucose requirement for chronic illness can be 4 to 5 gram per kg per day, or 60 to 70% calorie from complex and refined carbohydrate. Meal pattern should be small and frequent meal. We should follow the pattern of 3 to 4 meals, 3 major meals: breakfast, lunch, and dinner. Then in between breakfast and lunch, in between lunch and dinner, then after dinner we have to provide late evening snacks. Again, aggressive, even if we see that providing this much of calorie part from the carbohydrate, insulin resistant patient may fall into the hyperglycemia. So just let them go into the hyperglycemia. Aggressive use of insulin, OHA as necessary to maintain the normoglycemia can be followed, but do not reduce more of the carbohydrate because this is the primary source of energy in decompensated cirrhosis patients. Estimation of lipid and fat requirement for adults, approximately 1 to 1.5 gram 5 gram per kg actual body weight, up to 20 to 40% calories should be from the fat. Essential fatty acids should be taken care of so that deficiency can be prevented. As the patient comes to us with liver, any of the liver disease at any stage, they used to say कि हम तो बिना तेल का खा रहे, बिना हल्दी का खा रहे. So we should take the history of the patient so that we can prescribe the diet. The diet chart is not the diet chart only. As everybody knows, this is the nutritional prescription. So before providing the diet chart, before writing the dietary prescription or nutritional prescription, we should talk to the patient and take a deep history whether the patient is not restricting. Even if we are saying कि नहीं आपको इतना तेल चिकना ही खाना है, many a time we encounter with the patient कि हम तेल और हल्दी खाते ही नहीं है, हम खाते ही नहीं है. But we have to thoroughly counsel them कि नहीं आपको कम से कम 7 से 8 चम्मच visible fat. If the patient is with the decompensated cirrhosis, so कम से कम 5 से 6 चम्मच आपको लेना ही लेना है. अगर ओबेसिटी के साथ आता है तो we can keep it up to 20% of total kilocalorie. But अगर वो normal weight पे है या sarcopenia के साथ है या frailty और sarcopenia के साथ आता है, so हमको उसका calorie और protein spare करने के लिए for body building and for maintaining their this muscle mass, हमें उनके up to 30 to 40% kilocalorie from fat रखना है और कहना है कि आपको 7 से 8 चम्मच a good combination of fat लेना ही लेना है daily. So essential fatty acid should be out of total fat energy from fat, 1 to 2% of total energy or 2 to 0.5 gram per day of linoleic acid. Linoleic acid should be included in the total fat intake. Linoleic acid 1% of total energy, alpha linoleic acid at least 0.5 of total kilocalorie, which is proven by the different studies. And so we should take care of the different essential amino acid while prescribing diet to the decompensated patient. The sources as mentioned here, lipid and fats. Consider problem. Usually what happens, patient comes to us कि हम fat already नहीं लेते हैं क्योंकि बाइल नहीं बनता. उनको गूगल से परसेप्शन है या दूसरों से परसेप्शन आया कि लीवर जो है कुछ ऐसा फंक्शन करता है जो फैट को मेटाबोलाइज नहीं कर सकता या डाइजेस्ट नहीं कर सकता उनकी भाषा में. सो हमें उनको बताना है कि नहीं, ऐसा नहीं करना है. बट बीइंग अ क्लिनिकल डाइटिशियन वी शुड कंसीडर द प्रॉब्लम कि बाइल सिक्रीशन रिड्यूस हो जाता है या हमें कुछ ऐसे कॉम्बिनेशंस फैट के देने हैं जो उनको इजी टू अडॉप्ट हों. ओबेसिटी डिकम्पेंसेटेड डिजीज में जब ओबेसिटी है तो हमें कैसे मैनेजमेंट लाना है. मेटाबॉलिक कॉन्सिक्वेंसेस ऑफ डिजीज मेक्स एस्टिमेशन ऑफ कैलोरी चैलेंजिंग. Glycogen stores remain low. Type 2 diabetes common. Almost everything has been covered by Nirupma. So I'm directly coming to this severe metabolic stress. This condition is severe metabolic condition. Calculate dry weight using this excess weight. When we found that BMI is this much, so we should consider the BMI. At least PENJ guidelines, we should follow the PENJ guideline, which is close to this BMI category. So we should follow the BMI category. Like if the patient is at 30 BMI and 50, 40, so BMI. So this PENJ guidelines has given a close calorie calculation for obesity. Sarcopenia already covered. Example, if the patient is see how to calculate the calorie, all this part is already covered by the previous speaker. Just I will show the example. One patient who is coming with the decompensated cirrhosis, 45-year-old male, Moderate ascites, jaundice, mobile and ward. Actual weight is 70 kg and height is 180 centimeters. So how do we calculate? Method 1 is here and 2 is here. Dry weight, we should consider the dry weight. The ascites is moderate. So we should reduce the 6 to 8 kgs weight for moderate ascites. So the present body weight of this patient is 70 kg. Minus 6 is 64 kg. Dry weight and BMI for this dry weight is 19.7 calorie per meter square. Then calorie requirement is BMR estimation according to Penge each. Just add the stress factor and activity factor. Requirement for weight maintenance calorie is 2,479 for this patient. And method B is directly like 35 to 40 kilocalorie. That comes 2,240 kilocalorie up to 5 to, because 35 to 40 kilocalorie we are taking. So plus minus 1,000 kilocalorie for weight gain. This must be 4,000 to 500. Sorry, by mistake, it's 100 kilocalorie for weight gain only. And protein requirement for this patient is up to 2 to 4.5 into 4, that is actual weight, is equal to 70 to 96 gram protein we can provide. Even we can go up to the 2 gram per kg of dry weight for sarcopenia and frailty patients. So late already has been discussed by previous speakers about the late evening snacks. And our director sir is also every time, even I have listened our counseling the patient कि आपको दिन भर जो खा रहे हो खाओ, लेकिन रात में आपको जरूर खाना है. He focuses on late evening snacks very much. So late evening snacks already discussed by the director sir. Every speaker has talked about this. So future use for this decompensated cirrhosis, being a dietitian, we do use calculating carbohydrate, protein, fats, and some of this macro and micronutrients. Again, I am going to focus on the pre and probiotic to improve gut immune function. So if the gut is happy now, the body is happy, the patient is happy. Yeah, I mean to say the person is happy. Use the omega-3 fatty acids as anti-inflammatory factor. Branch and amino acids should be discussed and should be used in whenever we are calculating about discussing about the protein. The main we should consider the branch and amino acid, late evening snacks composition, glutamine should be taken care. The summary, Penge is more tailored to the individual than EASL and SPEN. Earlier, even I am admitting that I have been blindly following the EASL guidelines. So I would request you, so just when the patient comes, just use your gut, your clinical judgment. So where the patient falls in the clinical category, and just then take the history and then decide if the really patient is obese, if the patient is really malnourished. So accordingly, you can combine the guidelines. So I am focusing here in the Penge guideline is more tailored to the individual than EASL and SPEN, as it allows adjustment of PAL, energy expenditure, in addition to the calorie for replacement or replenish condition. Supportive nutritional intervention is indicated in most patients with low BMI and ESLD. Nutrition support can and does improve mortality and morbidity. Yes, nutritional support for DCLD patient can do the wonder. Even I would say, I have been seeing the patient who have been sent to us, and if the patient is following us and comes in the follow-up, so we can again counsel them, insist them to do that way, and they really improve. Their functionality, their intake improve, their functionality, their functions of liver functions improve. Malnutrition should be identified and treated early. Close and regular monitoring is required. Dietary restrictions are rarely indicated. Earlier, it has been thought that protein restriction करना है हमें. HE में पेशेंट आया या नहीं आया, इवन विद ओबेसिटी या एंड स्टेज लिवर डिजीज के साथ आया, और हमें प्रोटीन रिस्ट्रिक्शन करना है. अभी भी बहुत सारे जगहों पे यही फॉलो होता है, तो प्लीज डू नॉट फॉलो दैट. सो डाइटरी रिस्ट्रिक्शंस आर रेयरली इंडिकेटेड अदर देन इफ द पेशेंट इज इन having ascites. So just we need to restrict the sodium intake. Clinical judgment works well for nutrition therapy for better prognosis. Thank you for patiently listening.